Good morning, everyone. This is Teresa Mendoza, and I just want to welcome everyone to the 2021 Data Analytics Conference. We have 2 days set aside for this virtual event and an exciting lineup of speakers. Next slide. So we want to really take a big chance. This is our time to thank our sponsors. And so we have Technion and SG2, who are our platinum sponsors this year, and QuadraMed is our silver sponsor. We are going to be having a sponsor bingo. So what that means is on the when we're not in presentation mode, you will see the sponsors banners on the left side and the right side. The platinum sponsors are on the left side of your screen, and QuadraMed, the silver sponsor, is on the right side. Every time you click on their banner and go to their website, and if you click on all three banners and go to their websites and check out their websites, you will get entered into a raffle for an Echo Dot. So please make sure you take time to visit our sponsors' websites. This helps keep our costs down for these events. Kevin, you want to play the Technion? We have a couple videos we're going to show you. Takes
On behalf of everyone at SG2 and Vizient, we thank you for the opportunity to partner with the Dallas-Fort Worth Hospital Council at this year's IQSC Data Summit.
Thank you, Kevin. So a big thank you to Technion, our platinum sponsor. Next slide. Hold on, I think something's SG2. Thank you to SG2. And then slide 5 is QuadraMed, our silver sponsor. So thank them all for being a part of this event, and please be sure to click on their banners and go to their websites, all three, so you can get entered into the raffle. Next slide. This event was planned by our planning committee, and I'm not going to read everyone's names, but I want to say a big thank you out to them for taking time, volunteering, helping get speakers, and be a part of this event. And a special thanks to Kevin, who is helping run this event in the background and support the committee. I want to make sure he gets recognized for all the work he's doing to help me today. Thank you, Kevin. Next slide. We have posters, so please visit our poster presentations during the break. That link will be sent out to everyone so that you can see the posters. We have 6 posters. You go click on the link, look at the poster, and then after you're done looking at all the posters, we have a survey on the website that you can go take, and that also enters you into a raffle to get an Echo Dot. So you have 2 chances to win an Echo Dot. One is with the vendors and going to their websites, all 3, and the other is by reviewing all our posters and filling out the survey at the end. And those links will be sent out for y'all to be able to go look at the posters. You can do that after the event. You can do that during the breaks. Just whatever you want to do. Also during the breaks, and after the event, we're going to keep this open until 12:30. So if you want to network and visit with other people at the tables, or go and visit any of our vendor sponsors, or talk to someone who has a poster here, you could go to find them and go to their table and visit with them. Next slide. So the Dallas-Fort Worth Hospital Council Foundation recently became an approved provider for CNEs. So thank you, Donna Crimmins-Bonnell, our nurse planner, for doing all the work to get the program for the CNEs. And to receive the CEs and the for HIMSS and for the CNEs for the nursing, you have to attend 100% of the sessions. The evaluation will open after the end of the sessions on November 4th for you to go take. We'll send the link out via email to everybody, and they must be completed by November 19th. And then we'll email out the certificates 1 to 2 weeks after the evaluations are completed. If there's any questions, you can send me an email. And at this time, we have no conflicts of interest with any of our speakers. And after the event, the post-event, we will have presentations and a session recording will be available on our website, and we will also send that out. With that being said, I'm going to turn the time over to the president of the foundation, Jen Myth, who will be introducing our keynote speaker, Dr. Philip Wong.
Good morning, everybody, and welcome. Welcome to the summit. As Teresa said, I'm Jen Myth. I'm the president of the foundation, and it is my great pleasure to introduce our keynote speaker for today, Dr. Philip Wong. He is the director for Dallas County Health and Human Services, and he's been in this role since February of 19. Prior to that, he served for 11 years as medical director for the Austin Public Health Department. He has an undergraduate degree in civil engineering from Rice. His medical degree is from UT Southwestern, and he also has a master's in public health from Harvard with concentrations in health policy and management. Dr. Wong also served for 2 years in the Epidemic Intelligence Service at the CDC. We are very fortunate to have him with us today to share his insights on translating data into actions during the COVID pandemic. Welcome, Dr. Wong.
Well, it's an honor to be here, and I want to start out by thanking everyone who's on this, and I'm sure all of you have played a big role in everything that we've been trying to do with this incredible COVID-19 pandemic, and it's truly been a team effort on all fronts for us to deal with this unprecedented situation. Let's see if are my slides up? There we go. Let me go to the next slide. And so, yeah, my objectives that I'm going to talk through are here, and I want to try to go through them fairly quickly to leave time for questions or discussion. But what I've tried to do is to understand sort of the data sources that we've been using with COVID-19. You know, this is, again, it's been unprecedented, and it's literally been building, you know, the plane while we're flying. With a lot of what we're doing, and I'll talk more about the detail and the data sources and ingestion and things that we've been doing. Then talk about some of the challenges that we've dealt with as we've been collecting this data during this evolving situation, and then how we are applying lessons learned from COVID-19 to the future. So hopefully there will be a day where COVID-19 is not at the same level of what we've been dealing with, and we can move on and build from there. And as Teresa mentioned, I have no conflicts of interest. So let me go to the next slide. So, you know, first, just to get an understanding of what I'll be talking about, I'm going to talk about a lot of the disease investigation for COVID-19 and our contact tracing efforts and the data systems that we've had to build or that have evolved during this pandemic. And, you know, this is something that we do all the time in other public health situations, you know, for sexually transmitted infections, for TB, for other reportable conditions. We get these electronic lab reports into our system. It initiates sort of a case investigation. We have our epidemiologists then follow up with those patients, collect additional information when appropriate. If it's communicable disease, then we, you know, identify if there are contacts. We then try to notify those contacts in many situations and follow up to tell them that they've been exposed or they've been reported to have been exposed. They should quarantine and monitor for symptoms. So this is sort of the basic system that we deal with in public health. But what happened with COVID was that this was, again, the numbers and the magnitude of what we were dealing with was much greater, certainly, than what we typically deal with. Now, we only do these on some reportable conditions. Again, I mentioned sexually transmitted infections, more like syphilis, HIV, TB, and then we don't do it for influenza because the numbers are normally way too many. We can't contact everyone who gets a positive flu test, something like that. But for COVID, we needed to do more of this case investigation, contact tracing on a larger scale. And so this is what, overwhelmed it certainly initially a lot of the systems that we had in place. And so the data sources, electronic lab reports, and these come from, from commercial labs, from hospitals, from physicians' offices. A lot of those, so there's sort of some dual reporting. Some of those reports are going to the state health department, and then they get that information to us, or some of them are coming directly to us, and some might be delivered to both. So there are duplicate reports that we need to sort through. But also, a lot of it, what you think back on the early days of COVID, and if you remember the difficulties with lab reporting and testing, and even getting approval for the test, and new places coming on board with different tests, and all of that. And so there were a lot of then providers, there were new systems being set up, drive-through testing, that they were not part of any electronic lab report systems. They're, building these and starting these up. We were getting paper reports, we're getting CSV files, we're getting all this mix of different lab reports in different ways. Then electronic initial case reports. These are some things from the hospitals this is actually a new system that we are working on and developing, and I hope many of you will or are already helping to participate with this. Parkland, Baylor Scott and White, THR, and if you're not already doing this, we hope you will join in, because this is pulling electronic, those initial case reports that trigger a case investigation, but they're now more automated to pull from the electronic medical records. So I know there's been a Texas EPIC collaborative, there's a non-EPIC collaborative to try to work with the EHR vendors, get these systematized and pulling from the electronic health records and electronic medical records and reporting into the national sort of public health lab system that then reports it to us and to the state health department. So again, I mentioned a couple hospital systems that, as a result of COVID, have started doing this, and it's a tremendous sort of advancement for us, so we can get off, because what the hospitals have been doing, and we're doing alternatively and are still doing, is paper fax reports to us or electronic faxes. And it's been said, we in public health have single-handedly been keeping the paper fax business going because, I mean, we've been taking paper faxes and having to hand enter this data. And as we started to get hundreds and thousands of cases a day, you can see how this overwhelmed a lot of the systems. As we've gotten to the vaccinations, then the vaccination data has been key in getting timely data for that. This is through the MTRAC system at the state. So every provider who was offering the COVID vaccine had to also say that they would report their information into the state. Again, building our systems initially for all the vaccinations. And when we started out at Fair Park and, having hundreds and thousands of people starting to come in, initially that was a paper-based system that we were, again, having 30 people trying to catch up and hand enter that data. But we have since made that totally electronic and upgraded our systems with that. Mortality data has been historically one of the key data sources that we use in public health. We get that from vital records, but that's typically a lot of times mortality data is very delayed after it's processed and all the coding and everything finalized from the state health department. Sometimes that can be two years delayed. But we have been getting initial reports from the City of Dallas Vital Records Department and the county clerk's office with vital records. So trying to get more timely data with that, as well as other reporting of deaths by the certifiers. But all of this data has been key to, and again, it's continued to evolve, a just continuing evolving situation as this has progressed. When you think about some of the data sources and some of the things here, let me go to the next slide. This sort of shows some of the processes that the labs are coming in to our systems or to the state health department. Again, electronic labs. Then you think back, and the state system was not prepared. There's a program, a system called NEDS, National Electronic Disease Surveillance System, that was collecting all these lab data, and the system was not built to handle the volumes that were coming in. And if you'll recall, again, thinking back as these reporting have been over since the start of this, there were times where we get these backlog of cases where there were, hundreds or thousands of lab reports that had been jammed up in the system. And then all of a sudden as they upgraded the system, we got this big flow and bolus of all these lab reports that had been delayed. So that has, really big implications on a number of fronts. First, and one thing I want to point out is just what we've seen with COVID is how important this data is, and having accurate and timely data. So, people are, hanging on to looking at the news reports every day. Oh, we had 400 cases, or we had 1,000 cases, and decisions are being made whether to close down restaurants and businesses and just require teleworking and the whole shutdowns and things decisions are being made on this data. And you look at the economic impact. The data is being used to make decisions that are affecting, trillions of dollars worth of impact on our economy. And so it just has shown how important this data is, but how a lack of investment in this public health data infrastructure had really, it really was shown and demonstrated during COVID-19. And again, when you think back, and I was telling you about describing all the different data sources, and so we're getting, lab reports, some of them reporting to the state, some of them reporting directly to us, some of them paper faxes, and then we're having to ingest this data, synthesize it, deduplicate it, clean it up so that our counts are accurate. A lot of the other things that we're doing, and I'll talk about some of that processing, but you can sort of see some of the type of in this flow chart, what we're having to do with this. We're getting the electronic initial case reports from the hospitals, again, this new system, so we can also get the reports from the hospital systems. And this is a system for the future. Coming from the electronic health records, we only have COVID data now, and right now it's only Tarrant County and us that are actually in the state that are collecting this and using it. But Houston is working on collecting this, and others, and now this will start to be able to be used for other non-COVID reportable conditions, and even other conditions like chronic diseases like cancer and heart disease, that we can start to get more of this hospital information electronically. That can, I think, really improve the timeliness and usefulness of some of our public health systems. Again, I mentioned the vaccination data, and again, this is a new that bidirectionality for vaccination data from the state just came out because of COVID, and hopefully this advances us so we can start getting this for other vaccinations. But getting that data, again, very important to get the timely data on that and see where we stand on getting vaccinations. If I could go to the next slide. So some of the issues and challenges that we've seen, and I've sort of alluded to this, it was constantly evolving and changing. And again, you think about it, what we've had to deal with as new tests come up, as now the rapid tests come up, as new providers who weren't ever doing these tests now start providing it, then they have to start reporting these to us, and they've never reported these things, so they just send paper information or spreadsheets, and at the same time, then everyone's clamoring and saying, why isn't public health getting us this information? I want to say, this has been truly a partnership and collaborative effort, and that again, many of the people I'm sure on this in this conference have been a part of it in various ways. I want to highlight in particular, Parkland Center for Clinical Innovation, the State Health Department, DSHS, CDC, all of the other hospital systems that have been working on this, really to try to improve and evolve as the needs have changed. But again, it has really highlighted how archaic the public health data systems have been, and how we need to invest in it. And that's what we're trying to do now, and I'll talk about that. But we need to also maintain this, because what's historically happened with public health and public health data is, after a big public health event that gets a lot of attention, whether it's H1N1 or Zika or Ebola or something like that, then there's attention to it. People say, oh yeah, we need to do something. And then in between those times, then people forget about it and then don't make those investments or continue those investments. What we've, also, and many of you, when people talk about our health data systems, they always think about clinical health systems and hospitals, and I know many of you are part of that, but public health has to be recognized as also an important part of these data systems. A lot of investments have been made in the electronic health records and all of those, but none of that was really going to public health data systems, and they are different. I mentioned a lot of the manual workflows that we had to deal with. And again, just think about how much with these thousands of cases a day, paper information, lab reports, and having to hand enter a lot of this information into this. The large volumes, again, even our initial systems, we had a REDCap database that soon into this, probably about 2 months into it, we the database couldn't handle the volume we had. It was we couldn't get information out, and we had to switch to a larger database. We did switch to Salesforce, and we've been working with Accenture and Salesforce on development of our system because, again, we did not have, when you're dealing with some of the, ingestion, case investigation, contact tracing for small numbers, we can handle it, but we really needed systems that could deal with the larger systems, and I'll talk a little bit about that. The deduplication I alluded to, that we're getting these information from multiple sources, and to just make sure we're not double counting these cases, used Salesforce and other tools to help with this. Address validation. This is something, first we have to make sure they're Dallas County, and everyone wanted the information on how many cases or how many vaccinations in our city. For COVID and other conditions like this, like Ebola, the EMS systems wanted to be able to notify their EMS providers quickly if there were people at certain addresses within their jurisdiction that had Ebola, in the past, or COVID, so that if they do an EMS run, they would know they should be doing universal precautions anyway, but that have additional information warning that, hey, someone with COVID is at this place we're being called to, and that was by state law. So having accurate data for all of this and being able to timely get that out was also part of this. PCCI, we've worked with them on some of the reverse geocoding so that we could get more of that timely and accurate address validation. The contact tracing systems, I mentioned, this is, again, when we get these cases started, initiated with a positive lab report, then we try to call those people and interview them quickly so we can identify contacts and then notify those contacts that they need to quarantine or watch for symptoms. But when you're getting thousands a day, it's very hard to do that. One of the things that, again, in partnership with Parkland and PCCI initially set up a system because we couldn't keep up with that early on. And so that within 24 hours, then we sent the information to Parkland and PCCI so that a Qualtrics survey, a text message or an email would go out to everyone within all the positive cases within 24 hours that had a link for them to do a self-administered survey and give us some preliminary information and also identify any contacts. And so electronically, then we could send information to that person and that contact and say, hey, you've been identified as a possible exposure to COVID. Here's some information about it. And then, we also had to set up a whole call center and build up staffing, and so that we had the systems that we could have more operators to make these calls and then monitor, the whole system for monitoring the calls, get data on how many calls are successfully interviewed, how many are incomplete. All of those had to be set up. The text message functionality, one of the tools that we identified in best practices is that sending out a text message beforehand to the people that were about to follow up with a call for an interview, and that greatly improved our response rates. Also, sending them text messages saying, look, you've been identified as a case, please call us back. And so we have a queue that we can then get these people to call back in and then be routed to our interviewers. And again, that was more efficient for making those case investigation interviews. But these are all sort of a lot of things. Maybe many of you already use these tools with CRM, your CRM solution, Salesforce. What we're trying to do is use the tools now, the modern day tools that are out there for all the rest of the world besides public health, for public health purposes. So using these CRM tools to keep in contact and make these connections. Also the reporting, the visualizations, the dashboards. Again, PCCI has done some of our dashboards. I'll show you some, I think, in a second. But now we've developed more with that, with our own capabilities, just getting these dashboards and data visualization so we can report it to the public internally, evaluate what's going on. And again, just the collaborations that I mentioned before have been so key throughout this. Next slide, please. So this is just a sample of some of the dashboards we now have. Fortunately, you can go on to the Dallas County website and COVID Master, sort of the main site. We have the cases now. You can hover over them. You can see the numbers by date. You can look at break it down and drill down by age, gender, race, by municipality. We've got the mortality data, the average number of cases per week or per day. All of these things now on our website. Next slide. This is our PCCI slide that we've had up for a long time with the vaccinations, showing where which areas have some of the higher or lower vaccination rates, and again, in partnership with PCCI, I've really been using that data to prioritize and identify census blocks that have the highest unvaccinated rates. We've then targeted those for block walking. We've sent text messages out to people in those and have tried to have pop-up vaccination clinics in those high priority sites, again, using that data. But again, with the vaccinations, then you can see the demographic breakdown of who's been vaccinated, what percentage of the population now vaccinated with at least one dose. So again, just more of this visibility into the data that we did not have certainly at the start of this. Next slide, please. So what we're trying to do, again, we hope that we foresee a day when COVID isn't, singly taking up all of our attention. We are trying to build off of what we've developed with COVID and try to apply it now to our future other non-COVID reportable conditions, as well as, trying to tie in also some of the other social services, things like that. And so this is what we're trying to do, build a platform so that public health isn't using second-rate, archaic systems, because we've seen how important these systems, we need to invest in this. So we are trying to look at what are some of the best tools out there for different functions that we're working on. And so we're trying to build off the Salesforce platform for our CRM. We're trying to make this scalable and work on the systems so that we're ingesting this broader data, the lab data, the EICR data from the hospitals, the other vaccination data, the other mortality data, bring it all into a centralized system and have it, again, give us this data visibility for other conditions. But we don't again, want to be using second-rate systems. If you look at a lot of the public health systems, they look like they were designed in the 80s and almost like with DOS sort of stuff. Next slide, please. This is some of like the data engine architecture that we're working on right now with Accenture. We're bringing in, gonna get in the lab data, the EICR data, the lab reporting data from the state health department. We're using Rhapsody and MuleSoft to do some of the mappings. We're trying to create a centralized data engine with Informatica MDM so that we can create, even use better tools for our deduplication, for our creating a single golden case record with all of these different data sources. And here's where, and then bring that from our centralized data engine out to Power BI so we can get that visualization on everything. And then also for the different disease investigation, contact tracing, use the Salesforce tools, the things, where now we can start looking at Google Maps in our investigations. And so for maybe a foodborne outbreak, if someone reports, oh, I ate at this McDonald's, we'll just click on that exact McDonald's on Google Maps, report when they were eating there. And if someone else reports they ate there at the same time, we'll have more easier ways to identify these common sources and things like that. Next slide. Finally, again, what we're trying to do is expand the data sources that we're bringing into. I've got, and so we hope to start getting chronic disease data into there. The other, we're health and human services. So some of our human services information, so that if people are getting housing assistance and other things, that we can then know that these patients that we're seeing perhaps with TB, do they have housing needs, and make some of those linkages. And again, use the tools that we've been able to tap into with COVID, and hopefully then bring these 21st century tools to public health as we move forward in the future. So that's a big high-level overview of what we've been through, what we've all been through, where we're trying to go with this. I think that, one lesson from this, it is going to take some investments. I hope you all will support us and keep, be another advocate out there for why we need to keep these things supported, even when there's not a COVID pandemic going on. I think it's to all of our benefits to have our public health data systems functional and up to date and timely and accurate. And again, it's going to be in partnership with everyone probably on this call. So let me stop there, and last slide is just open for questions.
So Phil, I see a question out there. It says, Phil, how do you suggest we address the lag time between the state's data and local regional data for future events?
So that's what, yeah, that's exactly what we're working on with the state, and we're actually convening these conversations with the state. We have Tarrant County, Houston also on board. We are, making sure that, and we are now trying at the local level, the state is now going to give us the feed to the pre-NEDS electronic lab reporting data. So everything that they get within hours after they receive it, before it even gets processed by their NED system, they're going to send it to us. They've already been doing that to Tarrant County and Houston. And so we will be getting that also to do our own processing, to take off, several hours or even a day to make it more timely and ingest that and be able to have our own local capabilities to do that. We're doing it hand in hand. Here's where there's some, looking at duplication of some of these services. But one thing I didn't mention, the state worked on developing a program called Texas Health Trace that supported some local health departments in their case investigation contact tracing. It was based on a Salesforce platform. But then the legislature, with their infinite wisdom, cut it off. It is being shut down as we speak. So what we've seen is we can't be totally dependent for instance, on the state, that there has to be some local ability to be able to get these data. If you recall, I think Collin County was one county locally that was dependent on that, and then they couldn't, because they were so dependent on the state reporting through NEDS. I mean, I think their county commissioners made a statement, we have no confidence in the data reporting, and had to shut down some of that things. So, what we've seen, we need to have dual systems that we can make and work together, but make sure that the data is timely. But the efforts that we're working on with the state will get us more timely data and through the state system. The state did upgrade their NED system so that a lot of the problems we saw early on have been resolved. But again, I think it's working together with them.
I turned my mic off. Do we have any other questions for Dr. Wong? You can put them in the Q&A box that's up on the right-hand side. Up at the top, it says Q&A. So if you want to ask a question about the data sources and the data flow and that kind of thing. I guess I have a question on, as far as like with having to stand stuff up so quickly, do you feel like you've overcome some of the early issues with the data and getting it out, and the analytics you have now, that you have something that you would feel confident in implementing if we were to have another pandemic?
Absolutely. What we've been able to build and what we're trying to build for the future really positions, us so much better than certainly where we were at the start of the pandemic. It's actually gotten some attention, media attention. We're actually one of the few places now that is getting accurate data on breakthrough cases and being able to analyze those with the new system that we have, and do more sort of drill down on which cases are having breakthrough from vaccination. And so, all of these, that's what we're trying to always be thinking about. How does what we're building for this, we don't want it to go away and that this is a one-shot deal. How does what we've developed, how can we make it apply for the future and help build our capacity and capabilities for the future?
Okay, great. Do we have any other questions for Dr. Wong? Okay, we had another one. It says, Dr. Wong, what is the CDC doing with their data to increase public education on vaccine efficacy, COVID trends, and confidence in the data models?
Well, certainly CDC and other partners. I know Johns Hopkins has done a lot of the data reporting. There are a lot of efforts to take the data, look at how even behavioral sort of studies on how do we address what are the reasons why people are hesitant for vaccine and for the public education messages, but taking all of this data and trying to look at the messaging that will again sort of address the concerns and reasons for hesitancy. But CDC, all of our data is reported to the CDC. That's part of the data systems. When we report it back into the state health department, then that's what we're trying to work out for, for COVID that's in place. And then how do we, as we're building this system using Salesforce for these other disease conditions, how do we report it back into the state health department and into NEDS, that then they can report that to CDC. But absolutely, CDC is, reporting and analyzing, as from the national level, a lot of the data that we're providing regarding efficacy, the trends that we see, and the data models. And I hope that answers that question.
Yeah, it sounds good. There's a lot of moving parts going on. I have another one, and it says, great presentation. What data related efforts are being implemented at the county level to address public health equity and healthcare disparities?
Sure. And absolutely, everything that I described being able to get that granularity was part of, looking at the disparities in what we've been seeing with COVID. And as we looked at, which geographic areas and which demographic groups were not getting vaccine or were having the highest impact from the number of cases, and looking at all of this, with a focus on health equity. If you look at, and I didn't go into the details, but when we first opened up Fair Park vaccination site, we used the data, worked with PCCI to identify those top 17 zip codes that were most adversely impacted. And Fair Park was initially focused and targeted to those zip codes that had the health disparities. So this is all tying into also before COVID, Parkland and the health department had released the community health needs assessment that showed that, just based on zip codes, our highest versus our lowest zip codes in terms of life expectancy, there was a 23-year gap in life expectancy depending on which zip code you lived in. And we continue to work with Parkland on exactly that, addressing the equity and disparities, and the role, what we're trying to do, and probably the role that the health department plays most in that is from the data standpoint. And so we're working on some specific projects with STIs and HIV. The health department gets some of those reportable conditions. We know where there are clusters of that. And so working with Parkland and then also some of our other community partners to say, hey, here's the hotspot. We've got a cluster of HIV in this community. Parkland has the COPC sites and other clinical services that we can all target and try to, identify people who are not in care, link them to care, get them on a sustained antiretroviral therapy, get them virally suppressed, all of these using that data, using the data, sharing what we have with public health data, uniquely we have because of our role in public health, and trying to then target the interventions towards that end. And then also we've talked about for evaluation, using the data to make sure that when we're doing these interventions and efforts, that they're making an impact. We've also had some discussions with PCCI on, looking at the social service and social determinant of health overlays and information that they have to try to, again, use that as part of our data sources that we use to make focus our interventions and prioritize those as well as to evaluate it. So some of the things I mentioned, we're trying to get some of our social services data and housing data into this, and we're doing efforts to address homelessness. And so this helps if we get these data sources more linked, when we invest in getting these persons on housed and other things, and we can start to evaluate what is the impact on either health outcomes or reduced hospitalization, emergency department visits, EMS utilization, other things like that. We're also interested in looking at, I know Parkland has the jail data. We have we're very excited that we've been working with them to get opt-out HIV testing in the jail so that it's a standard thing that everyone gets it at least screened and tested so that we can get them on treatment. But again, getting some of those data systems linked to help us identify problems, follow people, prioritize interventions, and then evaluate impact.
Great. So I noticed, obviously, you're doing a lot of work with the public health hospital, but have you reached out to Baylor or THR Presbyterian or some of the other large hospitals like Medical City on the Dallas County side to work with them, or are you strictly working with Parkland?
No, absolutely. And as I mentioned, the EICR, as a result of COVID, Baylor Scott and White was on board now in reporting now their EICR data. THR did. We would welcome anyone on this call, on this presentation. If there's one action, if there's something that happens as a result of my presentation, it would be great if you all look into it, getting your data reported into the EICR data. There's, again, a Texas EPIC collaborative. There's a Texas non-EPIC collaborative. If you afterwards, can link you with those groups if you're not already aware of them. But getting those hospital systems reporting into this electronic initial case reporting system would be great follow up, and we welcome working with all the hospital systems and have been. And we, as part of this, we also are epidemiology staff, and we work very closely with all of the hospital infection control practitioners. We have weekly calls with them and are actively working with all of the hospital systems.
Great. Do we have any other questions for Dr. Wong? Okay, well, I think great job. You got a lot of positive feedback on your presentation. And so we appreciate you taking the time to come and be with us today. Let me turn my camera on. There you go. So with that being said, I know you have other responsibilities. So thank you so much for joining us and presenting. And if people have other questions, are they welcome to reach out to you? Or
yes, absolutely, absolutely.
Okay. And with that being said, we will say goodbye to Dr. Huang and get ready for our next speaker.
Okay, thank you.
Thank you. All right. So we're a little bit ahead of schedule, but I know the next speaker, Gloria Kupferman, she's going to speak to us on a collaboration that actually we did here in Texas with AHA on opioids and the substance use disorder. Gloria, I've known Gloria now for about, I think, 5 years, 6 years, and she's awesome. I know she's flexible and can work with us as we speed along here. I've gotten to know her, like I said, over the last 4 or 5 years. She's awesome. She currently serves as the Chief Data Strategy Officer for AHA, and is responsible for the organization's information and data initiatives. Gloria oversees the AHA's data warehouse, the survey center, data products, and the resource center. So she has a big responsibility. Prior to joining AHA, Gloria was the Vice President and Chief Health Data Analytics for DataGen, where she led a team of analysts and developers to provide health policy-based analytic tools for the state hospital associations and healthcare systems and other stakeholders. Gloria is a nationally recognized speaker on healthcare finance and policy issues such as value-based purchasing, bundled payments, and Medicare payment rules. And she has a BA in mathematics and an MBA from the University of Albany. So with that being said, I'm going to turn the time over to Gloria and welcome her onto the stage. Maybe.
Yes, yeah, I'm here. I'm here. Now I'm going to try to share my screen. So, first off, let me just say thank you to Teresa and to Jen for inviting me to present to you all. I'm bringing a little bit of Northeast New York color to the Texas Dallas-Fort Worth Hospital Council. So I hope you all appreciate my nice New York twang here. And I also want to thank Dr. Huang for his presentation. It was extremely enlightening. And I've got all sorts of technology and data envy from here at the AHA, where, of course, we don't have that same access to that level of detail of information. And that's sort of what I'm going to get into here. So let me see if I can share my screen.
Okay, and I'm going to turn off my cam and mic and just give it over to you. Let me know if you need help.
Okay. Can everybody see my screen?
Yes, it's not increased. There it is. Perfect.
Okay, great. So, start out with today's objectives, which are to share the findings that we had and the lessons that we learned from this opioid use disorder collaborative study, and raise awareness of the issue and from a cost of care perspective, which is the whole purpose of the collaborative that we put together. I want to show what the power of collaboration can do to support state, local, and national data initiatives, particularly from an association's point of view, your association, whether it's the Dallas-Fort Worth Hospital Council, the Texas Hospital Association, the American Hospital Association. We're all responsible for advocating for our members' best interests so that you can do the good work that you do, bringing healthcare to your communities and dealing with important issues such as the opioid use disorder. And then definitely want to talk about what our next steps could be and maybe get some insights from all of you as to what you think our next steps should be. So a little bit about the multi-state data collaboration, or as I've acronymed it, the MSDC. This is certainly, this is a much larger scale than at the county level. And we're working with state and regional hospital associations, most of which do not have a direct real-time feed to your hospital's EMRs or ADTs or any other real-time data. But most hospital associations across the US do have access to the encounter data, the billing data, the administrative data, and either the state association or regional association collects that information directly, or they work in concert with the state or regional with the state health department or regional health department to get that information, because it's required to be submitted to the Department of Health in that particular locality. The AHA does not collect any of that data. We do not have any data that we collect on our own from our members about the people that they serve, that's at the person level, that has the information that's in the encounter data, that's in the medical record, that's in the EMR, et cetera. We only have the information we collect from our annual survey, which is much more descriptive about the hospitals themselves, but not the people that they serve. So we need to rely on the state and regional associations to get to that level of information that would give us a national look on healthcare that's being delivered and the patients that are being treated in our hospital inpatient and outpatient departments. And for state data collection programs, they're siloed. They also, each state or each regional association really only has the data for those hospitals and health systems that they represent. So they may have a very good picture of what's going on in the area that they serve, but they don't have a national look. So we put together this multi-state data collaboration to level the playing field and to give each state and local association a broader look of what's happening across the rest of the country. Are there lessons to be learned? Are there differences in what's happening from state to state? Do you have a hypothesis in your particular region that you're harder hit? You see news stories, you'll see sample studies done by a lot of researchers, but they're always sample studies. Nobody can look at the universe state by state and eventually, hopefully for the nation, to see really what's going on a much larger scale. The multi-state data collaboration is a true collaboration. We have a set of guidelines that and policies and procedures that we adhere to. We have a collaboration agreement. The agreement serves as like a master services agreement that governs the whole collaboration. But then within each project is its own sort of scope of work, or each project has its own project charter. So members of the collaborative can opt in to any and all projects, or they can opt out. But if you opt in, if the state opts in, that means that they are agreeing to share their state's data with everybody else who is opted in on that project. We all work together on it. We decide on which project we're going to do. We set the parameters. We set what level of aggregation we will report out the information. But once those states are in the collaboration and in the project, they have agreed that they will allow other states in that collaborative to see their data, everybody's data, and use everybody's data to publish white papers, to put infographics or dashboards on their websites, or to merge that data with other information they have to glean deeper understandings. Meanwhile, each state knows that we are all going to be analyzing the issue the exact same way, because we are all using the same algorithms and the same code. And this is for a couple of reasons. So I call this distributed computing. As you all know, when a state collects information from hospitals at the patient level, there's a business associates agreement, it's person level data, it's HIPAA protected, it's privacy protected. So we wanted to avoid any discomfort at the state or local level. We wanted to try to get as much data into this collaboration as we could. So it was determined that each collaborator would run the code in their environment and share only the aggregated results with the AHA. The AHA then compiles all the results and puts together a data set, a primary set of analytics, and that goes out to all the collaborators. But then again, everybody's the data, the compiled data is there so that everybody can use it and analyze it their own way as well. So that avoids the problem of sharing person level data with the AHA, going back to each state or regional association's members and asking for additional permissions or new BAAs to share that person level data outside of the state or regional association. So shared distributed computing. But what this also means too is that we do need to be cautious of small cell sizes. So sometimes our levels of aggregation, depending upon what we're looking at, if it's something that's going to be very rare, like an opioid use disorder might be rarer in some counties or in some geographies than it is in others. And so we have to be very careful that we, not disclose any data that's not aggregated high enough so as to not run afoul of privacy and HIPAA rules. As I said, an AHA collects everything and puts it all together and provides output. We work together on the algorithms. So why opioid use disorder? Well, we have a technical advisory group, and we discuss what each state is facing, where are some commonalities, where is their interest, where is there a need to collect this data in order to inform what the association is doing in its advocacy work, what the association is doing to support their members. And also, many associations have initiatives, particularly quality initiatives, where they're working with their members to improve performance on certain metrics. And so this is a great opportunity for associations to look at and see where they see improvement. And if several states are conducting initiatives to improve performance, they're each doing their own thing. They can take a look and see what are the trends. My state versus another state that's running a different initiative. Am I seeing similar results? Am I seeing better or worse results? So a lot of opportunities to compare and contrast and benchmark across states. The opioid epidemic has been just a blight on this country for over 20 years now. I remember, it was probably in the early 2000s going to a meeting that Teresa and I go to, that's of the data folks from all the state associations across the country. And one of my colleagues from Virginia was talking about how they're seeing this uptick in opioid overdoses and opioid sickness, and they don't understand what's going on. Has anybody else seen this happen? And a few other states raised their hands saying they saw this too. And other states, I was representing New York at the time, other states were scratching our head. We had no idea what was going on. And look at the spread now. And of course, now we're moving into the synthetic opioids as well. So this has been a plague. And our hospitals and health systems and our state associations and regional associations are working hard to work with, to help our members, with opioid stewardship programs, reduce the prescriptions, move to non-addictive pain medications, et cetera. And I have some statistics out here that you can read on the slide, and you'll have those later. But the big thing that came out in our discussion was many states were already doing their own analysis of, what they were seeing in terms of opioid overdoses and opioid use disorder. But they were all each looking at their own state, and they all each had their own methodology for how they were looking, which diagnosis codes, which procedure codes they were pulling out of that encounter data to indicate opioid use disorder. And everybody wanted to be able to see the bigger picture. And we at the AHA want to see the bigger picture because, and we're not quite there yet, as you'll see, but being able to put the number on it in terms of lives, in terms of, and in terms of costs to the system and costs to hospitals in caring for this, very important from an advocacy perspective to really quantify that return on investment that justifies, action, real investment in solving this problem and reducing opioid prescribing and opioid use in the U.S. So the business objectives for the project were to identify, the first was just the burden of care. We started small. We needed to start small for several reasons. Not every hospital association has the same depth and breadth of information. So we wanted to go to the most common denominator for information that we could collect. So we wanted to look at the burden of care. What percent, what's the rate of incidence of individuals coming to the hospital either with a primary diagnosis of opioid use disorder or a secondary diagnosis that complicates their care of opioid use disorder, or even, a subsequent episode that is a result of opioid use disorder. So that was our main objective, just understand the burden of care. So we want to quantify that prevalence. We want to track the progression. So you'll see we have 3 years worth of information in this analysis. We held off because everybody's been very busy under the COVID pandemic. But we do need to go back and we need to take data for 2020 and now 2021 because we do believe we are going to see an uptick in most states, as we've been reading this in the press. There's been a lot of surveys done on this. So our hypothesis, I should say, is that we're going to see an uptick in opioid use disorder during the COVID pandemic. And as I mentioned, to be able to measure and track outcomes and compare and contrast. So these were our business objectives for the multi-state data collaboration. The parameters were, we started with CMS had come out with a series of codes for substance use disorder. And they have those codes as part of their chronic conditions warehouse, and they put those out there for public use. So we started with those codes. For those of you that don't know, here at the AHA, we own the UB4 codes. So we license the UB4 codes, and we have a coding clinic here. So we worked with our coding professionals here to tease out those ICD-10 codes and descriptors that were specific and could only be attributed to opioid use disorder. Then we met with our colleagues that were participants in the collaboration in this project, who had already done some work in this. Ohio had done a lot of work in this area. Colorado had done a lot of work in this area. West Virginia had done a lot of work in this area. So we sat down and we compared and contrasted with what they've been looking at and what we were looking at, and we came up with the set of ICD-10 codes. And as I said, our starting point was to look at opioid use disorder broke into 3 areas: no overdose or complications, with an overdose, with complications, but no overdose. We did end up combining all 3 because fortunately, very fortunately, the overdose numbers really tended to be small numbers in terms of presenting to the hospital. That's not to say that opioid use overdoses are not a problem. It's just that, not all of them come to the hospital. And we eliminated any encounters where opioid use disorder was not present on admission. And that was a long discussion, but the thinking of the group was that there could be instances where somebody was prescribed opioids in the hospital and had an adverse reaction, and we didn't want to pick that up as opioid use disorder. So the end result was an issue brief that the AHA put out with co-authored with all of our participants, and everybody's logo up at the top there. I can and will share the issue brief. Teresa has it because they were a participant in this collaborative, but I can share it again just in case Teresa doesn't have it right at her fingertips. So there was the issue brief, and then we provided all of the background data, and we also prepared our own set of Tableau dashboards, which we shared with the group, and I will share with you now in these slides. So first, in the end, we ended up with only 19 participating states that we could report on. We had a couple of states that could not provide the full amount of data that we were looking to collect. They didn't have 3 years worth of data. Some states, unfortunately, West Virginia did participate and they did run the data and they have it for their own use. And they have the collab. They were a collaborator, so they did get all the information from other states, but we did not include them in the report because they did not collect ED encounters, and so their data was not comparable to the rest of the states, and it really made them, they really stuck out like an outlier without the ED data. So we left them out. And some other states that had wanted to participate, but then just couldn't run the code or, didn't have the depth of data that they thought they had. So 19, not bad, not the whole country though, and certainly would have liked more than that. So the first slide here, and it might be small on your screens, but you will have it in the slide deck afterwards. The first slide here is showing you from highest to lowest, and it's looking high, and it turns out it's just basically highest in all 3 years, except in a couple of standout places. The state by state, so 3 bars for each year. 3 bars, 1 for each year, 2017, 2018, and 2019. And these are encounter rates per 100,000. Okay, so of the 19 participating states, showed lower encounter rates in 2019 as compared to 2017. But three reported reductions of more than 20% in their opioid use disorder encounter rates. And those were South Dakota, Michigan, and Wisconsin. But 5 states did report an increase in their opioid use disorder encounter rates: Alaska, Illinois, Montana, Nevada, and Texas. The most substantial of those was Alaska. So, and you can see here, maybe you can see here, maybe not. Now, the state way at the far left here is Mississippi. Okay, so something that I don't think, has ever been done before. Certainly it would be more robust, more compelling if we had 50 states in here. But this is still, a very large look at what's going on. And what each state now, as I said, is able to do is really compare and contrast, speak to their colleagues at their neighboring or like experience state associations, and talk to those that have seen some success in reducing opioid use disorder, and talk through what's happening in their state and what could they possibly do in their own state. Also, I want to just point out that now that although we rolled this up by state, as I said, because it's aggregated and we don't share patient level data, each state association has all of the data in which they can reach out to individual hospitals and take a look at the rates at the hospital level, which we don't have and we didn't want because, again, of sensitivities around certain hospitals' experience. But the state association has this information that they can, if they're doing any performance improvement an initiative, they know who they can reach out to where they would have the greatest impact. The next thing we did was to take a look at whether or not there's a difference between Medicaid expansion states and non-expansion states. So what you have here are these box plots. Okay, the lines at the extremes of each box plot, and these are the years. So it's 2000. The first 2 box plots are 17. The next 2 are 18. The next 2 are 2019. So you can see the range from lowest to highest. You can see the median is where the light and the dark grays move in, and the range is the 75th percentile. So you can see, how much variation there is. And what we found, and this was interesting, was that the median encounter rates for expansion states was higher than the median rate for non-expansion states. So, and a lot higher. And we don't, a potential explanation, though we searched the literature, we could not find anything in peer-reviewed literature that verified this hypothesis. So it's another hypothesis that we could possibly dig into. But a potential explanation is that perhaps with Medicaid expansion, individuals that have have an opioid use problem and might be more likely to seek care and services at a hospital in an expansion state if they don't have insurance of their own. It's a hypothesis. I can't back it up with anything. The next thing we looked at was whether opioid use disorder had any correlation to poverty, the percent poverty. And of course, we're looking at a state level, not a county level. So again, this is not going to show perhaps as robust a correlation as might otherwise be seen if you were looking at a more granular level. But with the 19 participating states, there seemed to be a moderate positive correlation with an R squared of between point 2 and point 3 between utilization rates and the state's percentage, poverty percent of people in poverty. The next thing we looked at, because this was something we had seen in the literature, was the opioid use disorder rate per encounter. What is it correlated to the percentage white population? And this was also surprising, but there is a moderate negative association between 0.4 and 0.5 between opioid utilization or rates and a state's percentage of white residents. So the rate goes down as the percent white goes down. And then the last thing we looked at was the opioid use disorder rates, and as run against percent rural population to see if there's any correlation between, because you read in the literature too about this being a rural problem. Again, all of this is at the state level. When you pull it out, and look at the county level, you may see stronger or weaker correlations. My guess is you see stronger correlations, but right now, using just the state rates, we don't see any meaningful correlation or association between opioid use disorder encounters and rural versus urban population percentages. So what did we learn here? First off, collaboration requires trust. And it was to get even the number of participants. I think we had, maybe 25 folks that signed the project charters. Those 25 associations to a place where they were comfortable and confident that we wouldn't reveal anything that could look bad for their particular hospitals or for their state, that we weren't going to be collecting patient level data, that we were all going to, use this data wisely and could be trusted. That took a while. All that conversation took a while. But the collaboration did bring a number of perspectives to the table and did bring a much richer understanding of the analysis and what we need to look at. Certainly, I would never have thought, but I'm of course not a clinician, and fortunately we had some quality folks involved in our collaboration, that the concept of the subsequent sequela, that that somebody could have come to the hospital with a principal diagnosis that's really a result of the effects of opioid use disorder. So we did include those subsequent sequela codes in our analysis. Collaboration takes a lot longer than we expected. This wasn't everybody's primary job. It wasn't top of their list. It wasn't their priority. And this certainly wasn't a requirement. This is a voluntary endeavor. So, it was a fine balance for us at the AHA to work with everybody and, gently remind folks that we needed them to run their code. We were running this on a quarterly basis for a while, getting them to share their code, get their data, and getting them to run it and submit it without hounding anybody, since again, it wasn't their main job. You definitely have to have a business reason for all participants. So, you never get 100% consensus. Part of the reason why we didn't get 50 states is that there were some states that really weren't concerned about opioid use disorder. It wasn't on their list of priorities. So, you have to work with the majority, but you definitely need to have a business reason. Everybody needs to have a reason to do this, or you're not going to get any uptake. And it was very, very important that all the participants were on a level playing field. They all had equal standing. They all knew that, everybody put in and everybody took out equally. Next steps. As I said, we need to update with 2020 and 2021 data. Our hypothesis is that we're going to see an impact of COVID. So that might be a very interesting and finding, and something that this data set will have, tremendous impact on the conversation around the COVID pandemic and its side effects, so to speak. And it will be an exhaustive study, at least for those states that are participating, because it's not a sample, it's the universe of hospitals. It's not the universe of the population, but it is the universe of hospitals. We need to develop, the next step is, at least what I would like to do, and we need to vet this and make sure that all of our participating states can do this, is we'd like to be able to cost this out. So it's one thing to have all the encounters, but we need to come up with a way to cost this out. I mean, one way, and the traditional way to do this would be to tote up all the charges and multiply by a cost to charge ratio. That's what we tend to do in the regulatory world. We tried to do that. We got some really kludgy results, and I'm sure that has a lot to do with the cost to charge ratio. So I think we need to think of a better way to try to cost this out. Another thing to consider as we move forward, and certainly would take a lesson from all the data collection that's been going on around COVID, is if we could find a cost-effective, secure cloud instance where all of the data could be put up in the cloud with nobody, with it being, de-identified and safely stored, so that we could run the analysis with the same code on the full bolus of data in a cloud instance, as opposed to every state running it in situ. That would probably add a lot of efficiencies and make it possible to perhaps do a lot more if-then type analysis. And then, I'm open for questions and other thoughts. So I'll click to my last slide, which is, questions and comments. I'll stop sharing so that I can see people and you can see me, and see if there are any questions, comments, or suggestions.
Great, thank you, Gloria. I will tell you that it was fantastic working with the AHA on this, and there were challenges definitely with, getting everyone on the same page. Everyone's data is coming in differently. I would love it if we could come up with a way to standardize the data collection with all the states, but everybody's doing something different. So that was definitely a challenge. So if you have some questions, we have the Q&A box over there for you to go put in a question. And just FYI, you can also ask questions anonymously if you don't want your name on there. I'm kind of interested in the last slide, Gloria, where you talked about the cloud collaboration. And so my question to you would be is AHA looking to do something where everyone loads their state data and then, it gets shared that kind of way, or just specific state data that you're looking to?
So, we need to, the trust factor is not to be, underestimated. So we really need to understand, which is why we did the distributed computing to begin with. Not every state has different relationships with their members in terms of how they collect the data and what their business associates agreement says. And there are still some states where they get the data from their state Department of Health, and the state's departments of health are even trickier to work with in terms of sharing person level data. So, to my mind, my big, hairy, audacious goal would be that we do build something that's better than HCUP that we at the state and regional level could do our analyses on. Similar, the work that you do at Dallas Fort Worth Hospital Council. I mean, it's just amazing. And I would love for us to be able to do something like that more in a larger scale for all of our members. But that's probably unrealistic at this point. So so what I'm thinking is limited data sets that would be, project specific, a cloud instance where, folks load their data, it gets used, the analysis is done, and then you blow the stuff, the raw data away so that it's not sitting there and we just have the output. That would probably be the best way to do this so that we can maintain and build trust with the state and regional associations and with our members.
Great. We do have another question here. Oh, and I did want to tell you, I went and looked to see if I had the final brief, which I was pretty sure I had, but I cannot find it. So if you don't mind sending that to me, I will get it out to everybody.
I absolutely will.
I could have sworn I had it, but I searched all my files and I have the final brief, but not the final copy. So
okay.
So we have a question here that says, how can more attention be publicized to our nation as a whole as to the data regarding opioid use, since it is becoming more prevalent and used in damaging to human life, expressly our children? So does AHA have anything that they're doing?
We do. We haven't done anything recently, but we have some materials out there. We always, on opioid use and opioid stewardship. I think a lot of that sort of got overtaken by COVID this past year and a half. We are, renewing our focus on behavioral health issues overall, but substance abuse issues as a big component of that. And like I said, that's why I think it's important that it's not just about the incidence and the burden of care. We really need to take it to the next level. And, I know that the Missouri Association did some work in this area as well. We really need to come together and take it to the next level and put it in terms of lives lost, years of life lost, and cost to the system. How much more it costs the system to treat the disorder than to prevent it. So we really have to do a better job there. There's no doubt.
Someone anonymously suggested our social media pop-ups away.
Scrolling
through Facebook and,
I was going to say, I think I have maybe 1,000 followers. I don't know if that's going to do it. We'd need a big platform for that. But, the AHA does have, we have access to, we're the premier healthcare lobbying association nationally. I mean, we're right up there. Pharma spends more than we do, but we're right up there. So we have Congress's ear. We need to do a better job, and it's a matter of priorities. And right now, the priorities are getting COVID relief dollars and making sure that, that this new Build Back Better bill doesn't cut any money to hospitals. But once we got past those hurdles, you're absolutely right. And I don't know about social media. I've never been very good at it.
Well, I think, with this analysis, what we're trying to do is get a feel for it, right?
Right.
And, from a community standpoint, how can we use that data to impact the community and make people aware? Right. And, is it a campaign where we do something along the lines of, making the community aware that, try Motrin first, what's
right.
What's the thing? How many lives, I like that, how many lives are lost, because people don't understand I don't think average consumers living in their home understand the impact that opioid is having on families. And so maybe, trying to do something from a consumer point of view. And Jen Myth is our professional on that. So,
and I, definitely that might be another really good next step is for us to reach out to, community organizations. There are associations of community organizations who might have data on, what they're seeing in the community in terms of whether it's Narcan use or death rates. And that we could merge this information with other information to make that a more powerful story for sure. But you're right. The first step was to see if, what we had here and whether it told a compelling story, which I think it does. Mm-hmm. And, each state association that participated in this, has the ability to go back to individual hospitals. That was, one of the main purposes of this, the ability to go back to individual hospitals and say, based on the data, compared to other states and compared to our state, you folks are an outlier. And it's not necessarily because it's what the hospital is doing. We don't want to say that. Right. That's not the inference. But you have a problem in the community you serve. Let's trace this back. Let's trace back these patients, find where they came from, find whether or not they've been, that they've been seeing a pain doctor or a pain clinic, or, what's going on here.
Exactly. That's a great point, Gloria, because for those that are in the meeting right now, we do have access to get a copy of the analysis. So, we could use that as a way to try to see if there's some actions that we could take with the data. And I think that's kind of one of the purposes of this conference is, what's the next step? How do we make that actionable? And not just for the hospitals, because the hospitals are concerned about community too. So right. How do we help the hospitals help their community?
Right. And I see one more question. Any other future plans for other conditions? The next thing we're working on, just so you all know, because we're watching you, is how another thing we're very concerned about at the AHA and at the state and regional level is the focus on social and economic risk factors and disparities in care, and being able to analyze whether or not there are disparities in care and getting to health equity. And towards that aim, we know that the federal government is going to start wanting to collect all sorts of information from our members about, the social and economic risk factors of the people that they see. And what's the low-hanging fruit here is those Z codes, the descriptor codes in ICD-10 that AHA fought really hard to get into ICD-10 and really aren't being used much when in the coding process. Understandably, they don't go towards any payment right now. It's a retraining process for coders, etc. But sooner or later, CMS is going to start using those, whether it's to adjust quality metrics for social and economic risk factors, or it's to do the analysis themselves on what they're seeing disparity wise. So it really behooves us to get our houses in order. And just like we did with present on admission, nobody was coding present on admission. And then, present on admission became a big thing because, of hospital acquired conditions. Mm-hmm. So we're doing the same thing, distributed computing, pulling use of Z codes. And what we're finding, of course, is between 2 and 4% of all claims have a Z code on them right now. And by and large, we're finding that the Z codes are only on behavioral health diagnoses. And the number one Z code is homelessness, is what's being coded. So, we've got a real bias in terms of how the Z codes are being used now. And that's just our preliminary findings. So that's what we're working on right now.
And just for our members, we just signed the project charter, so Texas is going to be participating, and we don't actually use our hospital council database. We're using the THCIC data so that we can capture the whole state for AHA. So
Yes.
hopefully we'll get that analysis to them soon.
Dallas
Dallas
Fort Worth has been a tremendous, I mean, between the knowledge base that you guys have there and the level of cooperation, I can't say enough about how much help Dallas Fort Worth has been. I also want to give a shout out. I don't know if anybody's on this call, but Parkland Hospital and PCCI are also, it's like some of my favorite people are down there in Texas.
Good to know. We have one more question here. It says, if it can help us prioritize education efforts and particular errors, both on the delivery and patient side, then it is incredibly useful. Maybe it's not a question. We have a target. We have to target our efforts given the scope of the need. So that's more of a statement, you know.
Yeah.
So
agreed. And I also I appreciate the comment from, let's see, who was that from? It was in the chat. The comment from Kevin Hall, who liked my New York accent. Yeah, that's like Nanny Fine, I know.
Oh, Leslie Moss also made a comment. They will have to start denying claims to force the coding of Z codes and external cause codes.
Well, I hope we don't get to that. I think that, what the plan is with the Z Code project is I've brought in our policy team on this as well. And AHA is going to be making an effort to, I'd hate to see this, work against us. I think that the Z codes are, ask Teresa after I'm off the call, how great it would be to be able to analyze your data using those Z codes to help you understand whether or not there are discrepancies in outcomes based on social and economic risk factors.
And she follows it up by saying, let's remember coders are coding for payment.
Right. Understood. Absolutely understood.
Well, great presentation, and I see thanks, Gloria, and we appreciate you taking the time to be with us today and be a part of our conference, and hopefully we'll be able to have you back again. I know that AHA has a lot of analytical tools that you've developed that you're doing, so maybe we can have an opportunity to get a chance for you to present what you're doing from that perspective.
Only if next time it can be in person.
Well, we appreciate you taking the time today. Thank you so much, Gloria.
Thank you everybody for having me.
Well, that brings us we're running ahead of schedule. So we actually have a networking break scheduled. We're going to take it we originally had it till 11:05, but I know one of our speakers we want to make sure they both have time to get on because they were getting on right before. So we're going to take it now till 11 o'clock. I think they're both here. So what this networking break means is we're going to go out of presentation mode. Y'all can click around to other tables and visit and speak to people at your table, but it also gives you an opportunity to go look at posters and to also click on our sponsors banners. Remember, you have to click on all three and go visit all three websites to be a part of the raffle, but you'll get an opportunity to do that now and at the end of the event today. So Kevin, if you'll take us out of presentation mode so everyone can go around and visit and, maybe take a little potty break.